there, and welcome to this presentation on chest tube ongoing care, monitoring, maintenance, and use. So before we get into chest tubes itself, we're going to do look a little bit at the thoracic pathophysiology here. So when we look at the chest, there we've got an X-ray there because we're going to look at some X-rays later. So that's kind of what a normal X-ray looks like, just showing where the lungs are sitting, where the sternum and the heart, your gastrophrenic angle at the bottom of the chest there, just showing where the diaphragm sits. And on the right side there, we got an easier breakdown of what we're seeing with the lungs. So we have the visceral pleura and the parietal pleura. So these are linings inside the chest. And in between there is our interpleural space or pleural cavity. So when it comes to chest tubes, when we look at that pleural cavity, if there's a small amount of air, small amount of fluid, the body can usually reabsorb that. It's not a big issue. But obviously when we get larger volumes of air or any kind of fluid in that pleural cavity, that can impair lung expansion and cause severe respiratory distress and even pressure on the heart if it gets bad enough with something like a tension pneumothorax. So reasons we put chest tubes in is to help relieve this. So if they have a tension pneumothorax, we're going to put a chest tube in to relieve that air. If they have something like a hemothorax or pleural effusion where they have accumulation of blood or any kind of fluid or purulent material in the pleural space, they're going to put a tube in to help it drain. So with that as well, we could also look at things like post-cardiac surgery or any kind of surgery where they're trying to just prevent fluid or blood accumulation that can impair cardiac or pulmonary function. And with that as well, we could look at things like chest trauma to manage bleeding, air, or prevent any complications like cardiac tamponade or pericardial effusion. So for example, here's a chest x-ray. So when we look at this, it's got a massive left pneumothorax. So when you look at the bottom there, they've got that little collapsed left lung when you compare it to the right, and it's causing some shifting of the mediastinum as well. So that's not great. So this person's got a date with the chest tube. And with this one here, so this is an ultrasound, this x-ray and ultrasound revealed a large right pleural effusion. So as you can see, that large wide area on the right, that's obviously not normal as compared to normal chest x-ray. So that is about 2.5 liters of fluid in this patient's chest. So this patient will need this drained, so they're probably going to get a chest tube to do that. So when we talk about chest tubes themselves, there's different kinds. They're also known as interpleural drains, which is more commonly referred to as a chest tube. So again, these are used to evacuate air, blood, or anything else from the chest. So there's a couple different kinds here. So the decision to use large bore, small bore, for EMS, it's not really something we're going to be concerning ourselves with. We're not the ones doing the chest tubes at this time. So based on what the hospital determines is required, we may see different ones on the patients. So again, for us, it's not something we're really going to make a decision. It's just good to be aware of different sizes. So we got the first one here. So this is a straight catheter. So this is just a simple direct tube, often used for fluid. For this one here, we have a small bore straight catheter. So these are often referred to as pigtail catheters. So these ones have a curled end designed to minimize tissue trauma and reduce the risk of dislodgement so they can stay in the chest more securely. We could have a small bore straight catheter. So with this, again, same idea. So this is chosen based on basically clinical need. So small bore may be used for air or some kind of fluid, but large bores are used more so for like blood or pus or some thicker kinds of fluid. So depending on what they're trying to drain, they may use a large versus a small bore. And as I said before, here's a large bore. This one we're probably going to see most commonly, especially with things like trauma, because this is when we get a lot more blood, pus, things like that. So again, there's 4 different kinds, not something we really have to decide for our patients, but just something to be aware of why they have these different size tubes so we can understand what's going on with our patient. So when we look at placement here, so for pneumothorax, so whether it's open, closed, or tension, so basically you got air in the pleural cavity, and usually when we get that, air rises and typically accumulates in the upper thoracic cavity. So as you can see here, when we insert a chest tube, they're going to aim it more up towards the apex of the chest there, and then that way we can get rid of that air. So it kind of goes up. We look at fluid. So this is a patient here with a moderate sized pleural effusion with some consolidation in the lungs. So with that, we're going to basically probably put the chest tube lower down in the chest to help that fluid drain. So something like this here. So this is a 74-year-old male with a history of hypertension, diabetes, and was having shortness of breath. And when they checked his chest, they found out he had a bunch of fluid in his lower lobes. So with that, they put a smaller pigtail, as I mentioned before, into the base of the lung to help evacuate that fluid from that pleural space. So again, for pneumothoraxes, they tend to go in and up, and for fluids, they tend to go more towards down in the chest. So when they do place them, we're going to place them in what we call the triangle of safety. So usually it's referred to as, usually they put them, chest tubes, in about the fourth or fifth intercostal space, similar to when we do needle decompression for air. They'll use the fourth or fifth intercostal space, and basically anywhere within this triangle of safety you may see a chest tube inserted, and that'll be dependent on why they're putting the tube in versus what the procedure is for. So again, like I mentioned before, chest tubes placed for pneumothorax are directed towards the lung apex, while chest tubes placed for pleural fluid are commonly directed inferiorly and posteriorly, again, just to help with that fluid drainage. So based on this need, that might be a different reason why they use one intercostal space versus another for your chest tubes. If we're going to be looking after these patients, such as a transfer or assisting in the ER with staff, we want to make sure that one has been properly inserted, and to make sure it's properly inserted, it should be secured and sealed to prevent air from fluid re-entering or fluid from re-entering the pleural space. So as you can see here, a lot of times these chest tubes will be secured with what they call a purse string suture to minimize the risk of dislodgement. So usually there's suture in place, and they'll put a dressing over top. So an inclusive airtight dressing should be applied over the insertion site, and then it's reinforced with tape to ensure a complete seal. So if we're taking over care of these patients or transporting them, we need to take a look at this before we leave the facility to another facility to make sure that that dressing's secure, the tube is secure, it's sutured properly, the sutures aren't loose, there's no drainage or leaking from the site around there, and that the tube is not kinked or dislodged. So again, it's good to look at the actual wound site, make sure there's nothing leaking through the dressing, because obviously if there's blood or some kind of strange fluid, such as pus coming out through that dressing, obviously the chest tube isn't secured properly, and we need to get it inspected before we go. We look at a continuous drainage system, so there's lots of different kinds out there in the market, but basically they all work the same by affecting the pressure inside your chest. So usually you have a higher pressure inside your chest, so these devices create a lower pressure outside the chest. So this would have a negative pressure, meaning it's lower than the pressure outside your body. So the negative pressure helps keeps your lungs expanded, and when air or fluid gets into that pleural space, such as post-injury surgery, that raises the pressure inside the pleural cavity, which can cause the lung to collapse. So a chest drainage system helps basically by creating a lower pressure than what's inside the chest. Okay, this pressure difference allows air and fluid to flow out of the chest and nothing to flow back in, which is very important. And that's because we have things like valves and water seals. So basically it creates a negative pressure that's lower than in the chest. So that kind of assists with the drainage of fluid and air. Go on any transport or take a patient to another facility with chest tube, we should really talk to the sending facility, familiarize ourselves with the device if we've never seen it before, or if we're not used to dealing with these, just to check in and understand what we're dealing with. So there are two main types of drainage devices. So we have wet and dry systems here. So the most important difference between wet and dry chest tube suction lies in the mechanisms creating negative pressure. So wet suction uses a column of water to regulate negative pressure, while dry suction uses mechanical regulator. So again, they work basically the same, just different things drive that negative pressure creation to help drain the fluid or air out of the chest. In the wet suction system, the water level controls the negative pressure. So as water evaporates, though, the negative pressure can change. So it's important to check the water level frequently. And with that, that's why we need to talk with the sending facility, because if that's something we have to keep an eye on while we're transporting, that's really important to know. If we have to keep checking water levels, what do we do if the water levels drop? That's a discussion to have before you take your patient. So the amount of suction is indicated by the water level, and generally gentle bubbling in the suction control indicates suction is working. So that's something we can familiarize ourselves with at facility. So here we have a diagram and shows the wet system there. So it's a 3-chamber chest drainage system similar to the dry system. The suction port can be connected to wall suction, and with that, atmospheric air is drawn into the suction control chamber to regulate the amount of suction. So with that suction, air from the pleural space will flow into the water sealed chamber, and bubbling will be visualized in the air leak window. Pleural fluid drained by the chest tube will accumulate in the fluid collection chambers, as you can see here. So on the right, we have dry suction system, which is what we usually come across more often in EMS. The negative pressure is self-regulating and is controlled by vents in a controlled release system. So it's different than the wet system. We don't have to watch water amounts. So this system can be set to suction or gravity, and unlike the wet suction system, the dry suction system is silent, and any bubbling indicates a leak. And we're going to talk more about bubbling in a second. So with that, with our dry system, we have 3 chambers again. And we actually have a physical control. So you see that little dial there that controls the suction. So again, that can just be through suction, applied suction or not. And with that as well, so similar, the air goes around through the top and it collects fluid in those drainage chambers. So the most common device we're going to come across is the Sahara chest drainage system, which is a dry suction device. So with that, if the patient requires a chest tube to remove or drain air, blood, or fluid from the pleural cavity, care really for us focuses on maintaining and troubleshooting chest tube draining systems to ensure that it functions properly and the patient is protected from any kind of infection. So let's review the different parts of the PleuraVac system. Since we're going to be using this, it's good to familiarize ourselves with all the components. So the first component we're going to look at here, this is the patient drainage tube connector and tubing. So the red clip is attached to the chest tube catheter to establish one-way seal for pleural drainage. So the locking red and blue connectors provide a quick connection if there needs to be a change in the drainage systems, which we're going to talk about a little bit later. So if suction is required, you're going to connect the suction to this port at the top here. So suction may not always be used on these devices. You may just use air, normal room air. But if you need to apply suction, you would just take this and attach it here on the top. Also on the top of this device here, we have a fluid injection port for air leak meter. So as you can see at the bottom, there's that blue fluid in the leak meter. If you're going to use that, they don't always put fluid into these all the time. Sometimes it's just air, but most of the time there is fluid, but either way it works. But if you do need to inject fluid into this device, you would take the syringe off the back of the device and put the fluid in through the top here. So this part here, this is the filtered high negativity relief valve. I strongly recommend you do not touch this. So this manually vents excessive negativity by briefly depressing the button to allow filtered air to enter the unit. We don't touch this unless it's requested by the physician or the staff at the facility. So the other part here, this is the big part, we have our collection chamber. So this can hold up to 2 liters or 2,000 mLs of fluid, so that's a lot of fluid. We also have the floor stand here at the bottom, so I strongly recommend you use this, especially if you're transporting a patient in the back of the ambulance. There are hooks on the side of this device that we can hook it onto the stretcher, but I'd recommend you have both the hooks on and the foot stand, the floor stand down as well, because that'll just help you keep it stable and prevent any tipping over and less movement of the device. Next thing we have is the dry seal and patient air leak meter. So like I said before, this may have fluid, it may not. You can just ask when you pick up the patient if there's no fluid, why they're not using it. It's not wrong. It doesn't have to have the fluid in there, but we do put fluid in there to help look for any air leaks and by watching for bubbling. And again, this is why we would put that 20 mLs into this device. Next thing we have is our suction control indicator. So this one's kind of important, especially if we're using wall-mounted suction on these devices. So this is an orange float in a window that means prescribed suction is imposed. So this shows you that your suction is working effectively and you have a good seal. And the next thing we have next to that is the dry suction control dial. So this suction level is determined by the position, the edge of the red stripe. So basically we turn this dial, they're preset to -20 centimeters of water pressure, but it may need to be changed based on what's prescribed by the physician and the needs of the patient. So with this one here, we would control our negative suction that way. So with that, we want to make sure that, again, that negative pressure is less than what's in the chest. So the best way to best practice for safe and effective drainage is we want to keep it lower. So ideally at least 1 foot below the chest insertion site so we can assist gravity for drainage. Okay, so we're going to make sure that we keep it clear. So we want to make sure that that tubing is straight. As you can see here, there's no kinks, it's not wrapped up in itself. There's no dependent loops, which is really important because that can cause blockages. And with that as well, we just want to make sure that we're keeping an eye on it. So when we pick up the device, we always want to make sure that we're keeping it in this position, as you can see here, ideally. But we also want to monitor the color, character, consistency, and the amount of drainage in the chest tube drainage collection unit chamber. So now if they're just dealing with like a pneumothorax, there may not be any fluid at all. So that's kind of good to note as well, because if all of a sudden there's fluid or drainage like blood, that could be an indicator something's not right, versus they're steadily got some blood or some pus coming out of there at irregular intervals. We want to get an idea of what we're dealing with so we can know if there's a big change or not. So if all of a sudden there's a sudden huge leakage of bright red blood and they've just had pus, that could be not a good sign. So that would maybe want us to redirect to a closer facility instead of finishing our transfer. So we want to make sure we're keeping an eye on all this stuff, especially when you're loading these patients into to the ambulance. If they're on the stretcher, make sure you watch all your tubing. We don't want any of the tubing getting caught in the mechanisms of the stretcher or underneath the wheel of the stretcher, because obviously that can cause tears, it can cause dislodgement of the tube, and it's just going to prevent drainage appropriately. Supporting these patients, we want to make sure that they're sitting upright, so this will help facilitate gravity drainage of pleural fluid and help with optimal lung expansion. And this position also can help splint the insertion site, so if they start coughing or anything, this can help minimize the pain if they do begin coughing. So when we're transporting, just like any other patient, we're going to be wanting to monitor our vital signs. The big ones we're going to be looking at for these patients, though, is going to be your oxygen saturations, your rate quality of respirations, and you could even consider using your nasal end tidal CO2. So we can monitor oxygen coming in, CO2 coming out. So that's what we want to look at. If we are transporting as well, you can tell your patients to notify immediately if they start developing any difficulty breathing, tightness in their chest, sudden chest pain, or if you notice on your vitals that they start having a drop in SpO2, or if they start developing rapid shallow breathing. Those are all indicators that something may be wrong with your patient. Before you transport, you can consider auscultating your patient's lung fields as well to assess for air exchange in the affected side, to note if there's improvement or decrease in air entry or no change at all, which might happen depending on the length of your transport. If you're looking at a longer transport, you may have decreased air entry. By the time you get to the receiving facility, it might have gotten better versus having a patient where you listened and they had good air entry when you left, and then they started saying my chest is really tight, and now you've got decreased air entry. That could indicate something's not working for you as well. So when it comes to this, so with the actual monitoring systems, so its key thing is to assess for air leaks versus normal air movements, and we'll have to watch the air leak meter. So that's, I mentioned this before, this is at the bottom of the device here. So this measure is air leaks on a scale of 1 to 7. So the higher the number, the greater the air leak. So we want to document this. So if a little bit of bubbling isn't abnormal, but if there's a lot, we definitely want to monitor our patient and document that that's what happened. So with that, to set up the air leak meter, the PleuraVac device comes with a sterile pre-filled syringe attached to the back of the PleuraVac device. So what we're going to do is we're going to take it off from the back of the device. We're going to take the cap off, and like I mentioned before, there's an insertion site on the top of the device itself. And we're just going to attach it in there. We're going to push the syringe down, and we're going to fill it up. So when we put the fluid in, it will turn blue, and that's totally normal. And that's how we want to set it up. So technically, if you are picking up this patient for a transfer, this should have been done for you already. So we're going to look at what do the bubbles mean. So when we look at the bubbling in the water seal chamber, so in the lower left corner of the device, we can see the air leak meter. So inside this section is the PleuraVac is a one-way check valve. It allows air to exit, but doesn't allow air to enter back into the device. You don't need water to create a seal, like I mentioned before. It can just be air. But what the water is used for is to detect air leaks from the chest cavity. But what that water is used really for is check the bubbles, see which is a greater leak. So when we look at the device here, see air goes in, there's a lot of bubbling there, so it's going up to about 3. That might be normal. Might be a small air leak from the lung. But if we have something like the tubes come dislodge, things like that, we could have a lot of bubbling. So you can see it goes all the way up to 7 there. So that is excessive bubbling. That's not normal. So that tells us that there could be a leakage. So the first thing we want to do is if we see excessive bubbling, so this is a little bit of bubbling and then it just spikes like that where it's a lot, we want to make sure we go from patient to the collection device, checking to make sure that any large air leaks aren't coming from breaking in the tubing. Maybe the tube came dislodged and we load them in the ambulance. It could be actual tear in the tubing, or the chest tube itself may have been dislodged. So this is going to be an indicator for us to check that on our patient. Other things we want to look for if we've got a lot of air leak concerns, we can gently palpate the area around. I wouldn't recommend routinely doing this if there's no reason to. But if we're looking at a leak and we can't really find what it is, we could look around the area for some subcutaneous emphysema. So we might feel crepitus, as you can see here in this first one. So you get those bubbles forming underneath the skin. And especially around the insertion site, this tells you that the tube might have become dislodged. So the other one here is we have a video of a gentleman here that they've just got a giant air pocket underneath the skin and they're basically just pushing it around. So if you see anything like that, I don't recommend keep pushing it, but it just shows us that there's air leaking somewhere from the tube underneath the skin, and that is definitely something of note and concern. So there's a difference between bubbling and tidling. So what we're going to see in this video now is tidling. So when you notice an intermittent pattern of bubbling that fluctuates with the patient's respirations, it's most likely that these pressure differences are coming from inside the pleural cavity. So this could be normal. So what you're going to see is the water in the seal chamber may rise with inhalation and fall with exhalation. That means that the tube is patent. It's doing its thing. It's what we want it to do. So as we see in the video here, we can see this going in. Okay. So you can tell there's a pattern to it. So when they're breathing, so it rises with inhalation, it falls with exhalation, it goes back and forth. So when you're seeing that, that's tidling. That's not a sign of a leak. That means that it's working appropriately, because obviously there's a change in pressure inside the thoracic cavity, and it's reflecting that on your seal chamber. So if we want to use wall-mounted suction, basically we're going to take our suction and we're going to apply it to the top of the Pleurovac device where I mentioned before. So you've got your suction port at the top. A lot of times when we transport, we don't use suction, but sometimes they need that extra suction for these patients, and that'll be decided at the sending facility. So that's a conversation to have. What do you want the suction set to? What do you want the negative pressure set to? But we just attach it to the top to our wall-mounted suction. So to decide what the negative pressure we want is, there's a suction control, and that delivers from -10 to -40 centimeters of water suction with calibrated control. So with that, usually it's preset, as you see in the picture here, it's preset at -20. It is up to the facility to decide what the negative pressure is. We are not going to touch that. We are not going to mess with that. So if they want it at -30 with wall suction enough to just get -30 pressure, we're going to transport with that. If they want -10, we're going to transport with that. We are not to be changing that. This is prescribed by the sending physician. So to make sure our suction is actually working, so you can see we've still got it set to -20, that's what they wanted. We're just going to apply our suction, and we're going to turn up our suction until this little float appears in the window. So this tells you that your suction is still good. Again, this is something else to watch, because if you do have a wall-mounted suction and that little indicator is at the top and all of a sudden it's not floating anymore, that could show us that we don't have active suction, such as there. Another one as well you might see they pointed to is the negative pressure indicator. So it should pop up as say yes. So that tells you do have accurate suction. If that disappears as well, that means you don't have accurate suction. So if your float drops and it doesn't say yes anymore, check your suction. It's either come loose, it's not working, or there's some kind of damage to the device or the tube itself. Sometimes it is possible to see that negative pressure indicator, the yes, pop up when patients are breathing just through changes in thoracic pressure. Again, look for patterns. If it's coming and going with their breathing pattern, that could be totally normal. So like I mentioned before, we have a negative relief valve. It's located on the top of the Pleurovac device. So this is used to assist when suctioning is changed from a higher to lower setting. Again, not a decision we'll be making. This will be decided by the sending facility or the receiving facility. So the patient, but when they change that negativity, the patient negativity may remain at a higher level unless it is relieved by using this valve. So basically you push it down, it relieves that extra negative pressure. Now the problem is if suction is not operative, or if operating on gravity drainage, depressing the high negativity relief valve can reduce negative pressure within the collection chamber to 0. So basically make it atmospheric pressure, with the resulting possibility of not letting air drain properly, so you can actually make their pneumothorax worse. So we don't want to be touching this button. This is something for the sending or receiving facility to deal with when they're changing their negative pressures, which we don't do either. So in the collection chamber itself, like I mentioned before, it has a 2-liter capacity. And the chamber is calibrated in 2 ml increments up to 200 cc's, and then until 10 ml increments after that. So we want to make sure we document how much was in there when we started a transport and how much is there after we get to our receiving facility. And then you can see here, fluid just goes over, whether it's blood or pus, just flows into each chamber up until 2 liters. Again, make sure to document what was in there, if anything. If it's got nothing in there, document that too. So document the amount in there at the start of your transfer and how much is there at the end of your patient transfer. If it's still draining, but the collection chamber is starting to get kind of full, don't wait till it's full all the way up to deal with it and switch over to a new device. When you start seeing getting into that last collection chamber, the shorter one, that's when you should be prepping your new collection device. So before you do that, I'd strongly recommend that you get it prepped. So get your new one out, get it out of the package when you get it, and get it all set up. This is not a sterile procedure to switch the collection units, but it is, we want to keep it as clean as possible, because anything like anything in medicine, we don't want to risk introducing infection into our patient at any point. So what we're going to do is we're going to take the pre-filled syringe from the back of the unit and fill up the air leak chamber. So as we mentioned before, we've got that fluid there. We take the cap off and we just insert it at the port at the top of the device. So you can see there's no fluid right now, and we'll insert it, and as we insert it, the fluid's clear when it goes in, but it turns blue once it's in the device. And we just do the whole syringe. It's preset. You don't need to decide how many mLs it is. You just put the whole amount of fluid into the device. Then what's going to happen is we're going to make sure that the dry suction control in the new collection unit is set to the same settings as the original collection unit, so we maintain the correct negative pressure. So for here, again, they always come at -20, but let's say the physician that sent you on the IFT with his patients on this collection device had it set to -15. We would want to make sure that our new collection chamber device has been set to -15 as well, so that way they're matching, so we're not affecting negative pressures. So then we're going to clamp the tube on the original unit once we're all set up. This is really important. We're going to make sure that's clamped. We don't want to expose it to room air because, one, it'll bleed out everywhere, and two, it can cause pressure gradient differences in the patient, which isn't good. So make sure you clamp it first. And then what we're going to do is we're going to separate the red and blue connectors on the new Pleurovac unit. So you can see it like that. And we're going to take the tubing from the patient, and we're just going to clip it into our new device. Then we're going to unclamp it. And then we're going to take our suction and again, double check to make sure it's as prescribed if we are using suction. If you're not, then you don't need to worry about this step. And then we reapply the new suction, again, making sure that that valve is at the top and it says yes on the pressure control indicator. So some issues that may come across when dealing with chest tubes. So if we have drainage that stops within the first 24 hours after chest tube insertion, it may be clogged by a clot or by a fluid blockage in a dependent loop. So again, we don't want our tubes looping over because that gives it some place for the blood to sit, and that can clot up and cause blockage. So we want to make sure our tubing is flat or at least straight. So when we look at it here, as you can see here, we got a complete occlusion. There's a lot of blood buildup in there. So we want to inspect for kinks, straighten out the tubing, make sure that's going to be our first go-to, because if it's just that, that's easy to fix. We want to make sure the patient's in an upright position. That can help ensure drainage as well. But the big thing is that if there's a big clot there, we're not going to fix that. So that's something of note. Again, this is something to check before we transport our patient. If we notice that there's a lot of dependent loops, or it looks like there's a lot of blockage going on, we might want to change our tubing before we leave the facility. If there is a lot of buildup inside the tube, some people may do what they call milking it. We don't want to milk the tube. That's definitely not our practice. So basically what happens is somebody might take the chest tube with their thumb and forefinger or their hand, and then they'll pull down on the tubing to try and squeeze all that blood or the clots out of the tube. They may try to like twist it or knead it to get the clots, break them up and move them out. We don't do that. That's not safe practice for us, because what can happen is when we're doing all that manipulation of the tube, that can actually generate pressures inside the chest tube, which can affect the thoracic pressure in our patients. So really for us, we're not going to do that. If it gets clogged, we're just going to make note of it. If the patient starts developing pain, things like that, because let's say they're draining blood and it starts backing up into their chest and there's a big concern, we could always contact vectors for direction, or we can just go to closest open, but we're not going to be milking this tube or anything like that. But again, something to look for before you leave the facility. If there's bleeding from the site, there may be some external or internal. So if you look at the site before you go, make sure it's nice and secure, make sure there's no bleeding. So if they have, normally like we wouldn't be getting someone like this with just the chest tube sutured, there'd be dressings as well. So see if the dressings bled through. If you do see blood there, ask the sending facility. If they're like, yeah, that's been fine, it's just how it is, that's fine. Just see if there's been any change. See if there's any like swelling around the site as well, because that's kind of a big deal. So if there's any interior bleeding inside the chest wall that could cause swelling or redness, we want to make sure we're checking for that as well. Make sure the dressing's intact, so we got that nice clean dressing on there, it's all secured properly, it's not going to half off. We want to make sure we check all of that before we go. Okay, if you do notice that there's some new bleeding or it looks like it's leaking through the dressing, ensure to tell the sending facility before you take the patient on the transport. That'll need to be addressed before you go. If the tube gets dislodged, so you can see here, like if there's a dislodgement here, so with picture on the left, there's no sutures holding it in anymore really. On the right there, the tube's completely out. This is a big emergent situation, so if for some reason by accident, I'm not going to say anybody's going to pull a chest tube out on purpose, please don't. But if the chest tube does come out due to reasons, what we're going to do is, this is a big emergency here, so now we basically have a giant hole there. So we treat it just like we would with any trauma patient, a large hole in their chest. We're going to cover it with our hand right away, and we're going to stick chest seal over top, or at least an occlusive dressing over top to prevent any air getting into the thoracic cavity. And we're going to redirect to the closest open facility. So if all of a sudden we're transporting and we see a sudden increase in bright red drainage, such as you see here, so this is pretty fast. So if all of a sudden you start seeing blood coming out of your patient, such as this, easily anything more than 200 mLs an hour may indicate vascular injury that requires surgical repair. So if you start seeing blood flowing out of the tube as fast as this might be a call to vectors to return back to the facility or go to HSC if that's an option for you, because that means there's some kind of possible internal damage or some kind of rupture inside the chest, and we can't deal with that. So that's closest open, or hopefully to appropriate facility if you have a conversation with vectors. We want to make sure we check for infection. So this might be the reason why we're transporting someone, is that they have an infection to the site. So with that, symptoms we're going to be looking for, just like anything else. They may be red, painful, feel warm to touch. They may need some antibiotic therapy. That's why we're transporting them. So with that, we want to make sure we're checking for this before we transport. If we didn't get a chance to check it before we transport it for some reason, we want to make sure we take a look at it and notify the receiving facility that it looks like there could be some infection around the site. So when we're documenting for these IFTs with these patients, so we want to make sure that we document if there's fluctuation of water in the water seal chamber. So again, if there was excessive bubbling and there was a leak in the tube and we fixed it, that's definitely something to write down. If we're noticing that tidling, again, that might be a good sign. That's just changes in thoracic pressure as the patient's breathing. We want to document that as well. If we used wall-mounted suction, what level we used, and that we confirmed that it was active and that we had positive feedback from the device saying suction was effective. We want to look at the amount of drainage and type. So again, was it pus? Was there blood? Was there a bit of column A, column B? Or was it just air? There was no blood drainage at any time. That might be a good thing. We want to auscultate breath sounds. Like I said before, it wouldn't be the worst idea before you take the patient to auscultate their breath sounds, and then auscultate before you get to your receiving facility to see if there's any changes, both positive and negative, or none at all. Patient's pain level or comfort level. So with that, put the patient in comfort. If they're complaining that it's uncomfortable the entire trip, we can give them pain control. But if that's not really working for them, that's something really to report, because it could be that the tube's moving around, it's dislodged, it's poking them in the lung as their lung reinflates. We don't know. So if they keep having constant ongoing pain, it could be signs of infection as well. So that's something that needs to be investigated. So we want to make sure we document that and report it. And appearance of insertion site or dressing. So again, if we pick it up, they've got a nice clean dressing on there. And as we get to the receiving facility, it looks like there's some kind of pus soaking through, or maybe just a little bit of blood. That is definitely something we want to document and report as well. Or did the dressing completely fall off and we had to makeshift one ourselves? That's something of note as well. And presence of any air leaks. So again, if there was any that were minimal, because let's say it was a little bit of tearing in the tube that happened en route, we couldn't really fix it in the truck. It didn't really affect the patient, but there was a little bit of air bubbling, or there was an air leak because the tube was dislodged, so we fixed it ourselves. Just anything like that, we want to make sure we're documenting it. And of course, if there is presence of subcutaneous emphysema. So we've got all that bubbling, and then when we check the site, there was subcutaneous emphysema. That's kind of a big red flag there. So we want to make sure we're documenting that and telling the receiving facility. Thank you very much for watching this presentation. And if you're ever dealing with a patient with a chest tube, a lot of times this is pretty much, we don't have to do anything. We just have to make sure the chest tube device is kept properly. Other than that, it's just a lot of observation and monitoring of your patient. I hope you found this video informative and you can use it next time you transport a patient with a chest tube. Thank you.